Welcome. We're here to discuss some of the late-breaking clinical science that was presented today at the American Heart Association Scientific Sessions. I'm Kristin Newby, a cardiologist from Durham, North Carolina.
Hi, I'm Eldrin Lewis. I'm a cardiologist specializing in heart failure at Brigham and Women's Hospital in Boston.
Hi, I'm Jose Joglar. I'm a cardiology specializing in arrhythmias from UT Southwestern Medical Center in Dallas, Texas.
So an interesting day in the late-breaking clinical science. I really thought the heart failure session was fascinating. Eldrin, maybe you could start us off by saying a little bit about Pioneer HF.
Absolutely. I was really impressed by Pioneer. We know from Paradigm HF that these patients who have chronic heart failure with predominantly class 2 and 3 heart failure have a significant benefit with the ARNI. But one of the residual concerns and questions was, there was a run-in period. So what happens if they're sicker and if they're in the hospital? And is it safe to actually start it? So in Pioneer, they actually looked at about 800 patients where the patients were acutely decompensated, they were stabilized, and then randomized to an ARNI, which is a sacubitril/valsartan versus enalapril, and followed. And in fact, the primary outcome was just looking at in-terminal proBNP. And there was a significant decline in in-terminal proBNP compared to the enalapril, even though both declined. However, secondary outcome measures were met as well, including the combination of MACE and cardiovascular death.
So it sounds like a huge advance potentially for us in practice. Jose, what do you think?
Yeah, that's right. One thing is this drug, the ARNI, has been only approved on my institution to be used as an outpatient. For example, nobody considered to be giving it as an inpatient, and also the possibility in the future it will replace as a first alternative. It will replace the ACE inhibitor or the IRB. Potentially, it's a possibility in the future. What do you think about that?
I agree.
And save us all the problem of having to think about conversion in the outpatient setting.
That's right,
So we're more likely to use it and actually reap the benefits of it.
Yes.
So on the flip side, another interesting trial in that session was what to do with people who have recovered left ventricular function, and do they need to stay on their medications the entire time? Jose, thoughts about TREAD-HF?
Right, exactly. And the issue, like you say, we never know what happens in the patients who recover. The heart is better. Do we stop this medication? We call them guideline-directed medical therapy for heart failure, including beta blockers, ACE inhibitors. Are we able to stop it? If we are, when that is. And heart failure tell us that we should not be doing that because it's potentially dangerous and harmful to the patient.
Right, and I agree. I mean, it's amazing how many people recover, and we define recovery as kind of New York Heart Association class 1 with an ejection fraction that has gone above 50%. And patients always say, can I stop taking these meds? And now, based upon TREAD-HF, I have to say no. It was actually a small study but powerful in that 40% of the patients actually had declinations. They failed the wean, and they define failure as a drop in your ejection fraction by 10%, and there are a variety of other parameters. It was well done. But the scary thing is 3 of those 20 patients who actually had a drop in their ejection fraction didn't recover by the end of the trial by reinstituting the therapy. And this is consistent with the epidemiology. So I think based upon TREAD-HF, I think we have to tread very lightly when we have to consider weaning. And I think in the majority of patients, we say that you're in remission, but you're not cured.
So 2 trials very impactful to how we practice. So let's turn to another one, and that's the intersection between diabetes and cardiovascular disease. And we've seen a couple of studies this session, one today, Impaheart failure, looking at the SGLT2 inhibitors. In this case, more of a mechanistic study. What did we learn from Impaheart failure?
I think Impaheart, there's been so much excitement with SGLT2 inhibitors because of the 3 trials that preceded this trial. And Impaheart, we saw a heart failure signal in all 3 trials. And the question is, what is the mechanism? So Impaheart actually looked at LV mass as the surrogate outcome measure. And in fact, patients who were randomized to empagliflozin in comparison to placebo, all with patients who were enriched with cardiovascular disease, had a significant reduction in LV mass. And it was not trivial. you know, and it was in a very short time period. So the interesting thing is that this is a link, you know, historically, if we see a reduction in LV mass, it usually translates into a reduction in heart failure events and subsequent mortality in hypertension trials. And if you look at the regression of LV mass and compare it to what you see with hypertension, it is actually much greater than you see with typical hypertension. The one thing that was interesting, though, is there was a difference in systolic blood pressure of about 7 millimeters of mercury. So one of the interesting things that I'd look forward to seeing is whether or not you adjust for the reduction in blood pressure and see if you have an independent effect on LV mass, independent of the reduction in systolic blood pressure.
Interesting. So Jose, you know, how do we get cardiologists and diabetologists on the same page about these new drugs and how we use them?
That's right, and that's an important consideration now that these SGLT2 inhibitors are showing improvement in cardiovascular outcomes. They're becoming sort of a diabetes drug to be used by the cardiologists in general to improve the outcome of our patient. A second study today showed improvement in heart failure hospitalization from one of these agents. So really, that's a debate we have in our institution and elsewhere. Who is going to be owning this prescription of these agents? Since again, these are diabetic drugs, but they improve cardiovascular outcomes.
And you know, Kristin, I remember there was also a very interesting study called the Neuroprotect study. Remind me, what was that about?
Yeah, so Neuroprotect was interesting, and it's trying to get into this space of how do we do a better job with neurologic recovery after cardiac arrest. And in this case, what they were looking at was management of blood pressure in the post-arrest period, and not targeting kind of the typical map of 65, but let's move the blood pressure up into the 85 to 100 mean arterial pressure using pressors, inotropes, whatever we have to do that. And what they saw was that doing that, using transcranial Doppler, improved blood flow, oxygen saturations stayed higher. They avoided kind of this reflex dip in oxygen saturation that occurs after arrest. What they couldn't clearly show was long-term neurologic improvement, meaning at 6 months, using the CPC score. At 30 days, there was a trend towards improvement. So I think what it tells us is mechanistically, there are things we can do to improve cerebral perfusion, to improve oxygen delivery to the brain. What we still don't know yet is, does it improve neurologic recovery? And that's probably going to mean another large-scale trial to determine that. Jose, anything that kind of caught your eye that you want to throw out?
Well, I'm glad to report that today we presented the 2018 new guidelines for the management of bradycardia and conduction system disease. And I'm proud to say that compared to the prior guidelines, these new guidelines are more patient-centric, meaning that instead of being a guideline about devices or about therapies, these are guidelines about patients. When we make recommendations through the entire patient experience, from diagnosis to interventions. And there is a great focus on shared decision-making, for example, and making sure the patient is the center of care, not the intervention.
Yeah, wonderful. And then there was this interesting trial called Regroup, looking at endovascular vein harvest for bypass surgery versus open vein harvest, triggered by an observational report from another study that showed actually worse outcomes with endovascular harvest.
That's right, and that's why it's important that we do a randomized trial, because sometimes observational studies can give you pitfalls, right? So in this is a trial done at the VA Medical Center, multi-center study, randomized perspective, which is very important, and show actually no difference in outcomes, whether the vein was harvested as a percutaneous approach or an open approach. And very important that the difference was not there. There was no harm because the patients prefer the percutaneous approach. It's better for patient satisfaction and comfort and postoperative care.
Perfect. Kind of tying together our patient-centered focus. So we hope this has been a helpful recap of the hot science from today at the AHA. On behalf of my colleagues, thank you all for your attention.
Thank you.
Thank you.